Thank you very much, and thank you very much for the invitation. It's an absolute honor to be here and to speak to you today. And Heba and I decided we will do it like I'm used at home with my family. I get to say the first words, but the last words I never get to say. So Heba is going to finish, and when we changed in between, because what we want to show you today is I basically was born with intestinal ultrasound. So I'm doing it now for 20 years. It's part of the clinical training in Germany to become an internal medicine specialist. So we do it from the beginning on. And Dr. Heba, she started introducing it to Kuwait. It was a much bigger challenge for her to get started than for me, and to prove you that it's actually doable in countries where it's not commonly used yet. Let me start with the first case, and I asked Dr. Sarah today already the question about this woman, what she would do in her daily clinic. And that was a 32-year-old patient, Crohn's disease, clinically asymptomatic. She was sitting across from me. I haven't seen her for several months, and she was doing absolutely fine. So what I did was, like Sarah mentioned, I drew blood for CRP, and I got the stool sample for fecal calprotectin. Now, those results I don't get back right away, and that patient came from 2 hours away, which in Germany is like a world travel to drive for 2 hours. So if I would have had those results, the CRP was normal and the calprotectin was 180. So I would have probably said, okay, that might be mild inflammation, but not much going on. I performed an intestinal ultrasound in that patient, and what you can see here is let me see the pointer. You can't see it up here. What you can see here is actually terminal ileum with an abscess. Let me see if I can just go in here. Oh, you can see it because I want to show it to you. I'm coming up here. I will walk over here. This is the terminal ileum right here. This is the fish with a small abscess. So, in a patient that is completely asymptomatic, what you see here is right away, that is a patient with a severe disease. And if I would have just talked to her and would have just gotten the lab results, this outcome of that patient might have been worse. So clearly, clinical remission, especially in Crohn's disease, is not always transmural healing. We will not reach transmural healing in all of our patients that we have from Sarah today, but this would be our ideal aim that we want to reach for normal bowel. And then if we need some cross-sectional imaging, the question is always which cross-sectional imaging is non-invasive, requires no preparation, is without radiation, can be performed by the treating physician right at the spot, immediately delivering data, including the real-time observation of bowel wall movement. And you already know the answer. It's not CT, it's not MRE, but it is intestinal ultrasound. And once you learn intestinal ultrasound, you will see you can do it right at the spot, and it only takes you a few extra minutes. And this slide you have seen several times today and in the past probably, because it's a very important publication. If you look at the details on the publication, you can see that cross-sectional imaging using intestinal ultrasound, CT, MRE, has been increasingly used in addition to endoscopic assessment as one of those additional sentences. The use of bedside bowel ultrasound has revolutionized our ability to assess the degree of inflammation in our body and allows frequent assessment, and has the advantage of assessing the entire gastrointestinal tract, including transmural healing. So already in the text of the STRIDE guideline, you find a few sentences indicating the usage of intestinal ultrasound. And we have learned a lot about intestinal ultrasound. If you look at the publication, you enter intestinal ultrasound and IBD. Until 2015, there are only a few publications. Since 2015, it's a rapid increase in publication on intestinal ultrasound and IBD. So we are learning a lot on how to implement, how to use the method, and what to make out of those results. Now, what, how, when, and which consequences before I hand over to Heba? Because that's important to understand. What do you need to look for? And it is very simple. The most important parameter is bowel wall thickness. And as the pointer unfortunately doesn't work, I hope you can see it with the arrows. This is normal bowel wall. The probe is on the top of the picture, then you have the abdominal wall, and then you have the 3 layers, which is black, white, black, mucosa, submucosa, muscularis. That's a normal bowel wall. And I think everyone in the room can see the difference between normal and abnormal. That is abnormal. Those are 3 layers, 7 millimeters. It's still the stratification is intact, but it's inflamed. And in all the clinical trials, that's the most important parameter. Then we look for stratification. Left on the picture, you see the 3 layers. Towards the right, it's just blackish, no stratification. Then we look at vascularization. No vascularization means lots of fibrosis, not so much inflammation, lots of color, lots of vascularization, more inflammation. And then we have one very important additional thing. It's first the mesenteric proliferation, the fatty proliferation around, which helps you find the inflamed bowel, but also it's a sign of more intense inflammation. And we can see motility. So on the right of the picture, you see a terminal ileum, which is the whitish thing that's in the middle of the picture moving over. And it's not the bowel that actually moves, it's the probe that's moving. And then on the left, you see a normal small bowel that's moving back and forth. That's how a normal bowel should look like. And that's the difference between a CT and MRE currently. The intestinal ultrasound, you can see motility, you can see activity, you can see if a stricture is a real stricture or just functional because there was just a contraction. And there's an expert consensus explaining all the different parameters, how to look for and how to grade them, and I very much recommend to look at that paper. And then you have to look for anatomical landmarks, and I often get told, oh, can you do small bowel ultrasound? Yes, but we are doing intestinal bowel ultrasound, which means small bowel plus large bowel, and you can see here in the cartoon that we are looking at the different parts, sigmoid descending, transverse ascending, and terminal ileum. And you have landmarks to actually find the right parts. Now, just one short image on how you find the bowel and what you do. That's on the sigmoid. That's my colleague examining the sigmoid. And you can see her probe moving over the bowel. And she's doing it very slow. That's slower than she usually is doing it. And still, it only takes a few seconds to look at the bowel. So that's done, and that's the sigmoid. That's how you look at the sigmoid, and that's what you then see by ultrasound. Again, in the middle of the picture, moving. This is in the middle of the picture, the sigmoid moving all the way across. And if you haven't seen intestinal ultrasound, you will not understand the image probably right now. If you have done a few, you will see completely normal sigmoid. So you don't have to worry about that sigmoid because that's completely normal. Now, what's the evidence? And we are not going to show you many data slides. There are lots of publications out. One showing the TRUST study in more than 200 patients, normalization of bowel wall parameters as early as 3 months after start of therapy. We have the STARTER sub-study, IUS response to therapy as early as 4 weeks after start of therapy. Crohn's disease and transmural remission at baseline has significantly better outcome at 1 year. So those patients that you scan in your clinic and that have a completely normal bowel ultrasound, those are very likely to be at 1 year in remission, no hospitalization, no steroids, compared to those where you find pathology. IUS response as early as 4 weeks post-start of therapy predicts endoscopic response at 3 months. And IUS can identify post-operative recurrence. And there's lots more to read, but Heba, how are you actually using now, with all the data in the clinical, with your patients, the intestinal ultrasound?
So thank you very much, Christian, for this overview. And you people, you would think that, is it like doable in our region or no? We doesn't have like enough practice because during our training program, we never like get exposed to intestinal ultrasound. So in real clinical practice, what do we do? Especially like in my center and my region. Let's take an example for a patient. So I have Mr. F, he's a Fahad. He's 25 years old gentleman who presented to me in the clinic in 2019. He was diagnosed as a case of terminal ileal Crohn's disease. He was a regular dosage of adalimumab every 2 weeks. The patient is very energetic, asymptomatic, had no problem. So he presented to my clinic, like I would say, a couple of weeks back, and he said, "Doctor, I'm doing well, I have no problem, but I have to tell you one thing, that I stopped taking the medication. I'm not taking it on a regular basis for around 6-month duration." So I asked him to go to the next room, and this is what I found. As Christian told us earlier, that because we doesn't have a pointer, but if you're familiar with the ultrasound image, you can identify, you can see that we have like some sort of bowel wall thickening where you can see the markers there. One is the longitudinal cuts, and the other one is the cross-sectional cuts. And in this bowel ultrasound, I found that the patient is having a bowel wall thickening of around 6.9, I would say 7 millimeter. And there is, I would say, sluggish or reductions in the bowel stratification despite it's still there. And the motility was slightly affected and the vascularity was slightly active. We sent a blood work and we found that he has an element of anemia with elevation of CRP. So I told him, why don't we proceed and do colonoscopy? And this is what I found in his colonoscopy. He has an ulcerations. Right after I intubated his ileocecal valve, I found the deep ulcerations with some sort of inflammations. And here it comes that in our clinical practice, we confirm the clinical based evidence. I know that the primary author of this ECO-ISGR guidelines is Christian. However, his recommendations is applicable in our clinical practice. So if we have asymptomatic patients with abnormal biochemical parameters, they may have some sort of disease flare or activity despite being asymptomatic. So after ruling any sort of infection, it's always good to proceed with endoscopy or cross-sectional images. It's not only about the disease flare, disease monitoring, but it's only an intestinal ultrasound can help us in identifying complications in our patients. So I have this Mrs. Munira. She's a 41-year-old lady. She was diagnosed in 2018 as a case of simple inflammatory terminal ileal Crohn's disease. She was at that time at infliximab combination therapy, and then she decided by her own just to stop taking the azathioprine. Then upon follow-up, she came out all of a sudden telling me that, well, I'm going to stop the medication, I'm going to follow a strict diet control, and I'll just follow herbal medication. I tried to convince her to carry on, and I guess most of you doctors are exposed to such kind of patients. I tried to convince her to continue taking same medication, but she insisted and she disappeared for around 4 years. Then, out of the blues, I received an email from her just to inform me that, doctor, can I see you in the clinic because I have a recurrent abdominal pain and weight loss. She came to my clinic, and when I took further history from her, she was admitted 3 times to the surgical site because of some sort of bowel obstruction. So we did the ultrasound immediately for her, and this is what I found in the cross-sectional image, that we have a bowel wall thickening in her, and there is some sort of loss of stratifications, and also you can see the surrounding inflammatory fats available. And then we don't have no pointer. And then when I check the vascularity also, it has some sort of pexels, and that is compatible, as Christian showed us earlier, with lumbar score 2. And at the end, while I was following the bowel and the bowel wall thickening, I found this lesion. This lesion, that means that we have like bowel ileal loops that's got connected together, and this is a fistula. So the fistula is a hypoechoic lesion that you can identify it connecting the 2 bowels. So I told her, now we're not dealing only with just fistula, but we're having an active disease and penetrating disease with some sort of complications. So I sent her for MR enterography to confirm this finding, and this is what I found, and I think you can see it genuinely, even in the pre-contrast images from the MRI, that the ileal loops are connected together, and there is a fistula between it. So again, back to the recommendations of Christian, that cross-sectional images can, and one of them is intestinal ultrasound, can detect the penetrating disease, including the fistulas and intra-abdominal abscesses, and also you can monitor such complication using intestinal ultrasounds. Other complications also can be identified using intestinal ultrasound. And this is a real patient that we can scan and you can identify it. And yesterday in the hands-on training and our symposium, we found 2 patients with abscesses. Usually abscess look like hypoechoic or anechoic lesion. As you can see, it's black with surrounding inflammatory fats. It can have some debris and air inside, and it has like a posterior echo hypodense area. And then if we compare, like a lots of prospective trials, they were looking about the accuracy of intestinal ultrasound in identifying such lesion. And out of 3 prospective trials, and with a total number of 240 patients, they found that the pool sensitivity was 84 in identifying such a lesion with a specificity that can reach 93%. Why this low sensitivity of 84%, simply because sometimes with the ultrasound we can't identify deep pelvic abscesses or like I would say something that's close to the gastric abscesses. And again, this statement has been confirmed using the ECHO-SGIR guidelines that cross-sectional studies, intestinal ultrasound is a good modality to identify such a lesion. 30% of our patients, and most of the gastroenterologists are aware that 30% of our patients, they will develop like stricture after a decade of the diagnosis. And 70 to 90% of the cases that we send usually for a surgical intervention are a patient with a stricture. And the strictures, they have like mixed between inflammatory and fibrotic. Our ultrasound machine can identify strictures. And for people who are familiar with some ultrasound images, I guess you can appreciate that we have a long segment of bowel strictures with loss of the echostratifications, and also the bowel wall thickening is more than 3 millimeter, and the strictures is less than 1 centimeter, and after that, the peristaltic dilatation with sluggish fluid in the lumen. So one meta-analysis had showed that out of 2 prospective trials with a total number of patients of more than 80, they found that, again, ultrasounds can identify strictures in with a good accuracy that carries sensitivity up to 90+% and a high sensitivity. And this statement has been also confirmed with the ECHO-SGIR guidelines that cross-sectional images can detect small bowel strictures, including the CT, MRI, and ultrasound. And ultrasound and MRI has a favorable options because it's radiation-free. And now back to Christian, because he has to give you some overview about intestinal ultrasound and ulcerative colitis.
Thank you, Heba. I think everyone would probably agree for Crohn's disease, cross-sectional imaging is important because it's a transmural disease. I think that's out of the question. But then when we get often asked, ulcerative colitis, why do we need ultrasound? We have SIGMO, we can see it with SIGMO, it's a mucosal disease. Why would you want to use a cross-sectional imaging for a mucosal disease? And all of us who are doing intestinal ultrasound frequently, they know that in moderate to severe ulcerative colitis, it is more a transmural disease. You see all 3 layers involved, and you often see the mesenteric proliferation. So it really helps you to understand the extent of the disease, the intensity of the disease, and it's easy to perform. And we have very good clinical data now on UC as well. So correlation of IUS and endoscopy, bowel thickness of 3 millimeters or more identifies inflammation on endoscopy. We have the TRUST-UC trial, more than 200 patients in 40 centers, normalization of bowel parameters as early as 2 weeks after start of therapy. And then we have the acute severe ulcerative colitis. You have a patient in your clinic with an acute severe flare, you start steroid treatment and you want to know, is that a patient who responds or who doesn't respond? And the trial from the Copenhagen group, the patient having had an ultrasound 48 hours after steroid start, they can differentiate between responders and non-responders. So already 2 days after start of a treatment, ultrasound helped them to guide their future treatment. And there is more and more data coming out on ulcerative colitis. And again, the question, Heba, are you using this in your daily clinic in UC as well?
Yes, I do, Christian. So, and this is a real example of one of my patients. This is Mr. M or Mr. Muhammad. He's a 20 years old gentleman. He was diagnosed with a case of ulcerative colitis managed by one of our colleagues, and he was just taking like 5-ASA and frequent, I would say, prescriptions of steroids. He came to the clinic and he said that, doctor, I have a lot of bloody diarrhea, abdominal pain. I came to you for a second opinion. So, and he came with his blood investigation that showed that he has a fecal calprotectin of 880, and he was having elevation CRP, anemia, and also he had like a panseptic cultures, including stool cultures, and everything came back negative. And, sorry, how can I go back? The video is not working. Can you play the video, please?
What's when if you click again?
No. Okay, no.
Go back twice, 2.
Again.
One more back, and then forward again.
Yes. So now you can see this, I would say the black shade, this is the sigmoid colon, and you can see it clearly that it's thickened with lots of stratifications, it's ulcerated and and even it's like extramural inflammation is there and some sorts of lymph nodes. So all the way I scanned the patient and I found that the patient is having some sort of left-sided inflammations. We scoped the patient with the flex sigmoidoscopy and we found that he was having elements of severe ulcerations and he was like easily to bleed. So we gave the option that in this case scenario, I was trying to convince him to go with biological therapy. The patient was like a bit iffy and he decided to go with oral medication instead of having an injections or infusion. So I started the patient on tofacitinib. Upon the follow-up, I decided to repeat the intestinal ultrasound after 3 months, and you can see the difference because initially there was a bowel wall thickening of 0.5 millimeter, and after 3 months, you can see a complete resolution and preservations of the host regions with the normal air artifacts and absence of the extraluminal fatty infiltrates. And this has been confirmed also by doing the colonoscopy, and you can appreciate the follow-up colonoscopy. So we do use bowel ultrasound in our regular clinical practice. So back to you, Christian.
Without going into too much detail, I would like to recommend 2 more publications. The one is Defining Transabdominal Intestinal Ultrasound Treatment Responsive Remission in IBD. It's a systematic review and expert consensus paper, and you can read the different statements of what to look for, how to measure it, at what time points to measure it. That's from last year. It's probably going to be updated again after a while, but right now that contains all the current data. And the second one is, we often get asked, how do you document? And there's an ECHO-ESCA topical review on optimizing reporting cross-sectional imaging, not just ultrasound, but also MR and CT, and I recommend to look at that paper as well. One point I want to make is the big difference between CT and MR. In MR, the patient goes into the room, goes in the machine, comes out of the machine. In Germany, the radiologist doesn't even talk to the patient afterwards, only the technician. Ultrasound, if you do point-of-care ultrasound, the patient is right next to you. You are talking to the patient. You are explaining to the patient, look, you are feeling fine, but there's still inflammation ongoing, and my patients very easily understand the images, what's inflamed or what's non-inflamed, and they're very disappointed if they don't see it, because they are taking a drug, they read Google and say, okay, it can kill me, and they want to know that this actually helps, so they want the follow-up. And we have clinical data here from Andrew Friedman, who showed that IUS may improve adherence with treatment and clinical outcomes, because it's for the patients a better understanding on what's happening in the bowel. So it is a very good interactive tool for point-of-care ultrasound. Let us finish off with an algorithm that we would suggest to use with intestinal ultrasound, and then a few comments on what you can do if you are more interested in learning more intestinal ultrasound.
So to wrap up this presentation, I would have asked, like, how can we monitor this patient and what's algorithm that we need to follow up our patient? And this is, I would say, like a wonderful proposal because it's a summary of multiple prospective trials that they were trying to know when can we monitor our patients. So if we have a patient with active inflammatory bowel disease, for sure we need to go with the gold standard, which is the endoscopy. But in addition to that, it's really a good idea to follow up, to do an intestinal ultrasound with some biochemical markers. Upon week 4 and week 6, you can, it's an optional, but you can do intestinal ultrasound to see if the patient has developed any sort of improvement or a reduction in his bowel wall thickening. And then in 3 months also, you can do the intestinal ultrasound with the CRP and fecal calprotectin. And I guess if you're following this treat-to-target approach, you should see your patient on a regular basis with 3 months interval, so you can insert our machine in between. In month 6 also, because you need to do endoscopy, so you can also scan the patients with some biomarkers, and after a year to make sure that the patient is in a deep remission or he's responding very well, you can do intestinal ultrasound plus minus MRI. And the idea behind this is to determine the transmural response at the short term, to monitor with a good objective markers, to rule out any complications. You can optimize your therapy during following up the patients, and to determine endoscopic remissions and transmural remission in the long term. So I would say this is a basic introduction about the intestinal ultrasound and the usage of intestinal ultrasound in our clinical practice. And here it comes like, what's IBIS? Because Dr. Maryam earlier, she said, welcome IBIS group. So IBIS Group, we're like a group of multinationality and international doctors who are really interested in using this tool. It's a non-profit organization, and the aim is to advance intestinal ultrasound in researches, education, and in clinical practice. And how can we use this tool in our IBD practice? And to improve the personalized patient's care and to help to contribute the management and the decision outcome. So if you are interested, because I've been approached by a lot of my colleagues, like how can we learn about ultrasound and how can we do ultrasound? IBIS has a good training curriculum that has been a good training curriculum that we can give it to you, and you can just have a good training to practice this intestinal ultrasound in your IBD patients. So we have module 1, module 2, and module 3. In module 1, it's just like I would say 2 days hands-on. This will give you a clue about intestinal ultrasound in our IBD patients, in which you're going to have a dedicated presentations and theoretical knowledge about how to use these machines and how it's applicable in your clinical practice. After that, we do subdivide our candidates into subgroups for hands-on training, so they can have the sense of how to hold the probe and how can they scan the patients. And also, we can use a simulator. We can show you with simulator any sort of complications. So if you visit our website, you can see that what's our plan and what is our curriculum for the upcoming module 1s in year 2023 and 2024. After passing module 1 or after attending module 1, then it comes for module 2. Module 2 is a 4 weeks intestinal ultrasound training in a certified IBIS center. You can find this in everywhere, worldwide, all over the world. So you go there, you spend 4 weeks with a certified tutor to teach you how to scan your patients for 4 weeks durations. The last module is the IBIS Echo Advanced Workshop, in which it's going to be a half-day workshop with advanced talk about intestinal ultrasound and the usage of the intestinal ultrasound. And at the end of this workshop, you will sit for an exam, and then you will receive your certificates that you completed the 3 modules of intestinal ultrasound. IBIS, it's not only about like giving knowledge and teaching the doctors and the candidates how to do this technique. However, also we like to socialize and we like to have some sort of networking. So IBIS came up with the get-together gathering for all of their members. So kindly register and be a member with the IBIS and come and join us at the UEGW at Copenhagen in October 15 for the get-together social gathering, and at the DDW in 2024 and 19th of May. In addition to that, after having a membership, you will be able and eligible to attend our webinar modules, because we do have like modules to give you more information about the usage of intestinal ultrasound in your clinical practice with our experts. Also, we do have the membership meetings, and it's going to be like virtual coming this October 25th, and also in February 21st, 2024, it will be at ECHO meeting. So to conclude this tandem talk, and thank you, Kristen, for joining me and being with me and supporting me to start practicing intestinal ultrasound in my region. So objective disease assessments in IBD at the time of treatment initiations and monitoring has become like a gold standard. It's part of our treat-to-target strategy in managing our IBD patients. Intestinal ultrasound is a good, accurate tool, cost-effective and non-invasive, and patient-centered tool to monitor our patients. It can be performed bedside, and you can have a quick answer upon what's going on and how the disease situations instantly and in a timely manner. IBIS has proposed the first international recognized curriculum for learning intestinal ultrasound, and more works is going on with the IBIS group and IBIS team to have a better learning curve and competency measures. Follow us, come with us, and join us, and follow us into our social media so you can know more about IBIS. And thank you very much.